Small incision deep lamellar endothelial keratoplasty. Technique and results by Mark Terry and Paula Owsley of the Devers Eye Institute and Lions Vision Research Laboratory of Portland, Oregon. The DLEK portion of the surgery begins with the placement of an 8.0 mm diameter circular mark in the epithelium, which is accentuated with a marking pen. This will act as a template for later resection of the recipient tissue. A scleral incision is made with a trifaceted diamond knife set to a depth of 350 microns with a length of 5.0 mm along the temporal scleral limbus. A crescent blade is used to create a scleral corneal tunnel, achieving a depth of about 75% into the clear cornea along the entire length of the incision. A straight Devers dissector is used to initiate the deep lamellar stromal pocket. This dissector is semi-sharp and broad-tipped to allow a smooth, consistent, and uniform dissection plane. The dissection is carried out to the mid-pupillary zone. A curved Devers dissector with a physiologic radius of curvature is then used to complete the stromal dissection beyond the apex of the cornea and maintaining a consistent depth of dissection. The stromal pocket created extends at least 1 mm peripheral to the template mark. A standard diamond cataract knife is used to enter the anterior chamber through the scleral corneal pocket at the location of the temporal template mark. With helon filling the anterior chamber, the highly curved intrastromal Cindy scissors are used with one blade in the anterior chamber and one blade in the stromal pocket to resect the recipient posterior stroma and endothelial tissue. Great care is taken to connect the dots of the surface template mark in order to accurately remove the desired 8 mm diameter recipient tissue. The new right-angle Cindy 2 scissors with extended blades are used to easily access and resect the difficult distal portion of the recipient tissue. The recipient posterior disc of tissue is then gently removed from the eye and placed on the surface of the cornea and checked for uniformity of cut as well as smoothness of the interface. Tip is then used to remove all of the helon from the anterior chamber. It is critical that no viscoelastic remain in the eye at all, or the donor tissue will not stick. Attention is now turned to the donor table, where a layer of helon is placed on the endothelium to protect the corneal scleral cap donor tissue. The donor corneal scleral cap is then mounted onto the artificial anterior chamber, which has been filled with Optisol, and the tissue is gently oriented along the widest diameter to keep track of the horizontal meridian for later positioning. The tissue is then capped into place and the pressure normalized. A recipient Barron suction trephine is placed to the surface and suction applied. Trephination was carried out to about 70% depth, and then a crescent blade is used to cut down deeper to approximately the 80 to 90% stromal depth. A straight Devers dissector is then used to create a very deep stromal plane and the curved Devers dissector is then utilized to complete this deep stromal pocket all the way, limbus to limbus, for 360 degrees. The horizontal meridian of the donor tissue is marked with an ink pen, and the tissue is uncapped, taking great care to leave the donor tissue still attached to the underlying post of the artificial anterior chamber. Great care is then taken to gently lift each edge of the donor corneal scleral cap to prevent collapse of the anterior chamber and any damage to the donor endothelium. The donor is then placed onto the barren punch trephine, endothelial side up, and the same size 8.0 mm diameter trephination is carried out on the donor tissue. Inspection of the trephine of the residual rim demonstrates a clean, well-centered trephination. A thin strip of helon is placed on the endothelium along the horizontal meridian of the donor tissue. With a forceps stabilizing the anterior stromal tissue, a capsulorhexis utrata forceps is used to gently fold the posterior stromal and endothelial layer in half over the protective helon. The tissue is actually overfolded by about 20%, pulling the anterior lip past the posterior lip as shown here. This will allow easy, spontaneous unfolding in the anterior chamber later on. The tissue is brought into the operative field and gently grasped with the utrata forceps, which close only at the distal tip to prevent crushing the tissue. The folded 8.0 mm donor disc is then gently and quickly placed into the 5 mm limbal incision into the anterior chamber, which has been filled with BSS. There may be some chamber collapse, so the anterior chamber is gently irrigated with BSS. As the chamber forms, you can see that the anterior lip of the tissue is already in position in the recipient bed, and the posterior lip is already starting to unfold. Further irrigation onto the iris surface and formation of the chamber allows further unfolding of the disc, with the entire disc now in the recipient bed. No air bubble or touching of the endothelium was necessary for unfolding the disc using this technique. The temporal wound is closed with 3 interrupted sutures and an air bubble placed to fill the anterior chamber. A reverse Sinskey hook is then placed into the anterior chamber, and the tip of the hook is placed into the recipient pocket, peripheral to the edge of the donor disc. And the hook is used to pull down the recipient edge at every location for 360 degrees. This is a critical step. If the recipient edge is not posterior to the donor disc edge, then the donor tissue will be dislocated the next day. This is the most important step of the procedure for preventing postoperative complications. After approximately 5 to 10 minutes, the anterior chamber air bubble is replaced with BSS, and the pressure is normalized and the conjunctiva is closed. In a separate patient surgery, we can demonstrate what to do if the donor disc unfolds but is left in a decentered position. In this case, the donor tissue has been placed in the anterior chamber slightly eccentric, and irrigation of the anterior chamber allows automatic unfolding of the donor tissue with excellent anterior adherence. Centering of the donor can be accomplished using a 30-gauge needle with a tip slightly bent to engage the stroma. The tip is placed into the interface from the temporal wound, turned posteriorly to engage the stromal surface of the donor disc, and the tissue is moved into the proper centration position. Of course, an air bubble and a reverse Sinskey hook must be used after this to position the recipient edges to ensure the safe adherence of the graft. We present on this slide results only 6 days after the deep lamellar endothelial keratoplasty surgery, which you just viewed initially. Remember that this 61-year-old lady's preoperative vision was only 2200. Here you can see that after 6 days, the cornea looks remarkably clear in the central visual axis, and her visual acuity without glasses is now 20/50 +1,